Clinical Consultation Network. We do this every Tuesday at 12:30. So we're very glad to have back with us today Adithyan Rajaraman, who has only recently come to Nashville. If you recall, back in May when he met with us, he was in Baltimore still. He was going to be moving down this direction. Well, he has now, and he is the director of research and what at Triad.
The director of behavior analysis research at Triad.
And behavior analysis research at Triad. And he's really quite an expert in trauma-informed care, trauma-based care through ABA. Trauma-based ABA, I guess is the right way to say that, is it not? And so we're very happy to have with us Adithyan Rajaraman. And previously we reviewed an article that you had been involved in where you start weaving in this idea of trauma-informed care with applied behavior analysis. And so really starting to weave those two together in a way that really supports people with disabilities. So we're so happy to have you back again, Adithyan. Thank you for being here.
Thank you so much. Thanks for having me. I'm thrilled to be in the state of Tennessee to speak with you all. I'm glad to get a second visit. I'm grateful that you invited me back. And to say that I'm to be an expert in trauma-informed ABA at this stage in the game doesn't mean much, if I can be completely honest, because of course, there have been practitioners who've been applying behavior analysis with a great deal of compassion over the decades. Oh, yeah. We just haven't really seen it creep into our literature and into our empirical research over the past 20, 30 years. So I would hardly call myself an expert, but I'm happy to be here to chat with you about what we've learned and about how we've kind of attempted to incorporate some of the pillars of trauma-informed care into ABA.
Yeah, that's great. Let's see, Babs, are there other announcements? Okay, I'm just going to quickly review what we've got upcoming, and then we'll get back into it, Dithu. So we've got next week, we've got Happy Ladders with Amy Jacobs Schroeder coming to work with us. She's out of California. She works with people with autism spectrum disorders, and she's going to talk to kids in particular. And so she's going to talk to us about her Happy Ladders program. On September 13th, we have decision-making supports with Penny Johnson. Babs, where's Penny from? She's going to have to look that up.
The ARC. Sorry, I should have put that on there.
Okay, the ARC. Okay, good. Thank you. Vocational.
The ARC.
The ARC. Oh, I misunderstood what you said. Thank you. All right. And then creativity, a case study with Andrew Hinkle, Estelle Stridham, and Danielle Osborne. They're going to talk about some of the work they've done in the seating and positioning clinic in West Tennessee. And then September 27th, we have our monthly NAD collaboration coming up. So we will be with you again there, be with you with the NAD organization again on September 27th. I'll just add a little bit to your introduction there, Dithu. So you've been blessed to teach, interact with, and learn from children with adolescents with and without disabilities for 14 years. Completed your doctorate in behavior analysis at the Western New England University under the advisement of Dr. Greg Hanley, one of the leaders in applied behavior analysis in this day and age. In 2019, he joined the faculty at UMBC, where he mentored undergraduate and graduate students of psychology with an emphasis in behavior analysis. In summer of 22, Dithu joined the faculty in the Department of Pediatrics at Vanderbilt University Medical Center, where he serves as the Director of Behavior Analysis and Research at the Treatment Research Institute for Autism Spectrum Disorders, which comes out to Triad as an acronym. Dithu has published research in the Journal of Applied Behavior Analysis, Behavior Analysis in Practice, and Autism. Dithu's research and practice interests include the assessment, treatment, prevention of dangerous behavior with an emphasis on investigating trauma-informed approaches to behavioral assessment and intervention. Research aim is intimately connected to the goal of being able to provide safe, dignified, yet highly effective behavior analytics services to underrepresented individuals in underserved communities. That's quite an introduction there, Adithu. Is there anything you want to add to your introduction there?
No, just that I'm a avid binge watcher of television, and that I've been thoroughly enjoying getting to experience the sights, the tastes, and the smells and the sounds of Nashville in my
Okay.
month and a half of being here so far.
Well, so that leads me to the question about your interesting fact or your fun fact for today. What do you have a fun fact prepared?
Um, I can proudly say that I've never visited Nashville, Tennessee, and not sang karaoke at Santa's Pub,
Oh,
which is a,
which
a
pub
local.
now?
It's called Santa's Pub.
Santa's.
It is not really a brick and mortar institution. It's more of a double wide trailer that stays open real late. And the owner has a big bushy beard, and he goes by the name of Santa.
Oh,
Uh,
okay.
I hope you can connect those dots, but it's always a good time
I'm
for
going to hit
karaoke
that
lovers like
place
me.
soon because I want to see you do karaoke. What's your karaoke song? Your
Oh man, this is gonna sound like I'm trying to please the crowd here, but I do really like the song "Tennessee Whiskey" by Chris Stapleton.
Oh,
Uh,
okay. So you can really sing then too.
I wouldn't go that far. It is
Yeah, because
it depends on how late you come.
You do a cappella singing, right? Did I
I did.
remember that correctly? Yes. Okay, I
That's
forgot
right.
about that,
Enough
but
about
now
my
I
life.
remember. Well, that's
Great,
so. Yeah,
great memory.
you're actually the guy that I resent when I go out to do karaoke
That's
because
not my aim. You're just gonna have to try it to find out for yourself.
I have to do something like "Whole Lot of Love" that doesn't require much intonation, in the way that you sing some of it. But anyway, that's great. Okay, well, thank you so much for that. But you're just busy doing this trauma work through ABA, and I know you've got a presentation you want to show a little bit here too. But tell us a little bit about this work. I mean, and we got into this a little bit our first time around, but what's been going on in this field of trauma informed behavior?
Sure. I'd love to. I could maybe do a little bit of a refresher for those of you that maybe weren't here last time. By the way, thank you all so much for coming and for joining in on this conversation. Just a little brief bit of my background is that I received some of my initial training in applied behavior analysis at a school called the New England Center for Children, which is up right outside of Boston, Massachusetts, and it's a school that serves some of the most kind of challenging and severe cases across the northeast of America. And received my training there kind of in the mid to late 2000s. And it was at a time where the New England Center for Children, similar to other institutions like the Marcus Institute here near in Atlanta nearby, and the Kennedy Krieger Institute in Baltimore, Maryland, they kind of had this status of being the place where you send the toughest, most challenging kids, and they kind of also had this reputation for being so well resourced that they were doing the state of the art best work with these children with really severe challenging behavior. And so I learned a lot while I was there. I'm very, very grateful for my experience. But on the other side of that coin, I also engaged in way too many physical management, physical restraint, timeout procedures that I'm proud of. And I did that for 6 years, just the same children that I was restraining in my first year in the name of safety and in the name of applied behavior analysis.
Right.
I was still restraining some of those same kids 6 years later. And so something about that didn't, when you're within those cultures, it seems perfectly normalized. And this is just the best we can do for these children. But once I was able to step outside of it and start to really learn about the broader behavior analytic, the broader world of behavioral services and just human services in general, I really started to see that I started to take issue with that, especially the fact that these institutions are those that are publishing and disseminating a lot of the work. We're taking a lot of our notes from places like the Kennedy Krieger Institute on how we're supposed to approach, address, assess, and treat dangerous behavior. So when I started to kind of work in public school settings and in clinic settings and in the home settings, some of those commitments didn't quite align. And I was really appreciative and grateful to learn from Dr. Greg Hanley about kind of a method for assessing and treating dangerous behavior that was a little bit more gentler from the start. It wasn't even, we weren't calling it trauma informed behavior analysis at that time. But it was a process that rather than just kind of hyper focusing on a singular reinforcer that might be reinforcing a singular topography of dangerous behavior, we took on a bit more of a holistic approach that kind of saw that these children who engage in really dangerous forms of behavior do so in multiple different types of environments, and oftentimes to gain access to multiple different outcomes, be it sort of either just tangible outcomes or attention from particular caregivers. But maybe a better way of saying it is that kids engage in dangerous behavior because it was the most powerful way that they knew to get the world to change in the moment to serve them. And when we started to embrace this notion that behavior kind of might serve multiple outcomes, or it might produce multiple reinforcers or consequences, you might say, that was a very, very powerful sort of paradigm shift, because it for multiple reasons. One is that it meant that these kids that we were kind of dangling along for several years, just trying to treat their attention maintained problem behavior, that we were able to look at a bigger picture and immediately be more effective in treating their behavior.
So,
But second,
I'm curious
yes,
about
please.
that, Dithu, because I often find that when I'm working with a situation like this, I've got to consider other factors besides attention that may be even the primary motivating factor in those circumstances. And that a lot of times when I do that, when I reformulate, say, based on more of an escape-based or fear-based type of response or trauma response that the person is having, that my treatment gets so much better at that point,
Mm-hmm.
and that I'm able to take actions that are going to be much more effective under that circumstance. Have you found that to be true? If so, how do you apply that? What are your thinking on that?
You're 100% right. And if I think that tracing that lineage might be helpful in talking about this. There was a time, many of us know this, there was a time when we were studying behavior in the rat and pigeon laboratory, and we were finding out really powerful things about the science of behavior by manipulating one variable at a time, by just seeing if food functions as a reinforcer, by just seeing if water functions as a reinforcer. When we were starting to translate that work into the applied setting, we never left the concept that we should always be careful in our science. We should be careful in our analysis of what our independent variables are. So we often tried to look for the one thing that was kind of driving the bus, that was reinforcing the behavior. What I think has happened is that 60, 70 years have passed, and we're looking at much more complex cases, children that live in a much more complex social world, yet we're still just we're fishing for that one reinforcer. So it's, to me, it's just at this point, it seems almost unbelievable that we as a discipline could look at a child who engages in such extraordinary behavior and think there's just one reinforcer for that behavior, because they do it across if you have a young kid, whether they engage in really dangerous behavior or not, that they have a lot of practice tantruming, and that they have a lot of practice using that kind of that negative behavior to get what they want in different situations, and they learn it across a lot of different contexts. So embracing, just assuming on the front end that rather than look for one thing, we try to look for all the things, it helps us create a more motivating context in which we can kind of teach replacement skills. It helps us just know the things that immediately will calm the child down, not just giving them one iPad, but giving them iPad with letting them sit on my lap and not making them do their chores. Those kinds of outcomes can be powerfully reinforcing. And when we have more powerful reinforcers, we can teach better skills, and we can teach more efficiently, and I believe more effectively as well.
I think that there are probably kids out there who might just have the one thing, but they never get referred to me. Unfortunately, everybody that I'm working with always has a much more complex sort of fabric to how they respond to things that really is the business of behavior analysis to try to explore it and figure out.
Mm-hmm. Can I say something that's
Yes.
a little bit outside of the data? I have a sort of hypothesis about this, and I think that the children and adolescents for whom and adults for whom their really severe behavior is really only reinforced by one item, that's a relic of the institutional culture that we used to have. If you were living in a kind of a boarded up room, and all you could do is hit your head, and that's the best way to get food or the best way to get the nurse to come to you, maybe that makes sense. But we've had autism awareness, we've had awareness of disabilities for the past 20, 30 years, and we have parents who are amazing parents who just are highly sensitive to the things that their kids are doing to try to sometimes prevent a major meltdown, to avoid it, you might say. But in so doing, these kids are learning that their problem behavior can achieve much more than just one thing in a world that's filled with toys, it's filled with their siblings, and that's filled with ways to get different people's attention. Sometimes it's that negative reprimanding attention, sometimes it's cajoling. So that's my hunch, is that, again, the science that has taught us that there's only one variable reinforcing behavior, I think it's a little bit of a relic of previous ways that we used to treat disabled individuals.
The fact that people were in such a poor environment that they could only go for the one thing.
Precisely.
Essentially. Well, and you mentioned autism spectrum because this is such a huge area, and I don't know if it's always appreciated how much trauma can play a role for a person with autism spectrum disorder. Because it's sort of like in the NAD organization, National Association for Dual Diagnosis, we talk a lot about something called diagnostic overshadowing. So if you've got a diagnosis of intellectual disability, people don't think about whatever else might be going on with you. It's all just related to that one diagnosis. It's another take on the one thing, so to speak. And I think the same thing occurs with autism spectrum. We don't, we think, okay, well, they've got autism spectrum, but do they have trauma affiliated with that? What's your thinking on trauma for persons with autism spectrum disorder?
I think I would be remiss if I said, oh, every child with autism has been traumatized. But what we know is that kids with autism spectrum disorder and individuals with developmental disabilities, intellectual and developmental disabilities, are at much differentially greater risk for experiencing traumatic events in their childhood relative to typically developing peers. And what I think is that rather than wait till we find out that our client has experienced some horrible trauma when they were 4 or 5, why don't we take a preventative approach on the front end, and maybe rather than call it trauma informed behavior analysis, why don't we call it trauma assumed behavior analysis? I think that there is just a pretty good likelihood that a child that you serve or an adult that you work with has experienced some trauma in their past. The extent to which that now results in like a post-traumatic stress disorder is completely unknown. And many of you may have experienced this. You get a new client or student in your classroom, it's not incredibly common to get a complete understanding of their trauma history. We often have to go digging for that information, or we get the client and on a rare case, it's like, oh, this child had severe history of abuse and neglect, so maybe be careful about this. But there are so many clients who slip through those cracks. So I think as a treatment approach, or as a way that we interact with clients, just starting with that level of compassion, of understanding that there may be some aversive experience that they may have a bit of a disproportionate reaction to, I think is a smart way to go about it. And that's sort of been my approach.
Yeah, I think one of the things people miss in that is oftentimes a person with autism spectrum disorder, because of their neuroatypicality, may react to something. It might not be something that the typical world even reacts to as a trauma, but yet it can be traumatic for that person with autism spectrum disorder. And so it probably, as you're saying, it should be assumed, probably in most cases, that people have experienced something that would be similar to somebody who went through a more severe type of trauma.
Yep. One of the very first kiddos that I worked with was 3 years old. So hardly had enough lifetime to experience too many traumatic events. But there was this winter jacket that if his mom even like said the J word jacket, he would have these half-hour meltdowns. And I suppose it all boiled down to at least the way that she was describing was that it was a little tight on him. And one time he felt like he was kind of choking, he couldn't breathe. So he just rejected the concept of the jacket. And that was something that, living in Springfield, Massachusetts, was pretty much a deal breaker. Like he needed to wear jackets. It was really cold up there. So that sort of became our exposure therapy, was in a gentle way. Can we introduce some level of warming coat or jacket that you can wear? But I think it speaks to your point, Bruce, that we don't know what these events are for typically developing people and neuroatypical folks. the kind of thing about trauma is that it can manifest itself in any stimulus. It just depends on what your experiences are with the world.
You know, Dithu, one of the things that to me seems like a little bit of a misnomer that a lot of people have is when you have an episode, because the guy you just described, you said if you presented the jacket to wear, it turned into a 30-minute episode after that. And so, you know, so if we're thinking about that from a pretty simplistic model in ABA, we're thinking, okay, well, this is escape related. He doesn't want to wear the coat anymore. But when it goes on for 30 minutes, is it really, I'm just interested in how you hypothesize surrounding the 30-minute episode versus just doing whatever it takes to not have to wear the coat.
Yes. Yeah. Well, I think that it can be a little bit of both. When I'm talking about a 30-minute episode, I'm talking about what mom describes happens in the home. And when we kind of bring that into our clinic, we are kind of, at least with this one particular case, we were able to show that if we just say, oh, never mind, this jacket, get rid of that jacket, and we throw it out of the room, that the child will calm down relatively quickly. But what mom will reveal is she's like, well, we had to go out shopping. So she's wrestling with him a bit. There's more to this episode than just coat, put it on, and then it goes away. There's coat, I don't want to put it on. There's some wrestling that goes in between. But to your point, Bruce, that the 30 minutes in between, there's a lot of learning that might occur there. There's a lot of aversive conditioning that might be happening there, where it's not just the jacket that's gaining aversive properties, but it's mom kind of wrestling you and all these things. So I just agree with you. I think it's overly simplistic to say that that's just an escape from jacket contingency. There's a lot more going on there, but nevertheless, depending on the goals of the family, we still need to address that escape problem along with the problem of the relationship that's kind of deteriorating in front of our eyes, because mom's forcing these issues.
One of the difficult things about it is trying to figure out, because, you know, as I've worked with these types of situations before, it's sort of almost as if at some point along the way, if it's an extended, you know, screaming, I'm just going to go ahead and call it a meltdown, even though we don't like that word as a behavior analyst. I think a lot of people understand what we're talking about. That once it gets into meltdown mode, it's sort of as if the function changes somewhere along the way, where it was originally about the coat, but now it's about something else. Maybe it's about a struggle with mom. Maybe it's just about the fact that I'm completely overwhelmed by the circumstance that I'm in.
Yes, I don't think we have a precise science of this, but I've always kind of looked at it from the perspective of we have operant behavior, that kind of behavior that tends to be modified by its consequences, the kind of behavior that has some effect on the environment. And we also have respondent behavior, reflexive behavior, the kind of stuff that we're not really in control of. And when I see meltdowns get to this really extreme state, where it just seems so disproportionate to the circumstances, we sometimes see kids' skin change. They become all flush. They start to really hyperventilate. They start to show signs that it's a lot more than just this operant struggle, if you will. And so I do think that behavior can kind of really easily bleed into this fuzzy territory where it's operant and respondent. And this is obviously a place where the language of trauma is incredibly helpful. The last time I was here, I think we chatted about a teenage boy who was bit by a dog when he was younger, and then when he grew up, even the sight of something like a fuzzy UGG boot gave him such a fight or flight response that he had a meltdown, what we call it. Another really common example is we see it in interventions for feeding disorders with kids with autism and intellectual developmental disabilities. We often it's the best practice we have out there is not pretty. It's something called escape extinction. It's called non-removal of the spoon. It kind of involves strapping children in and then making sure that they eat the food, because it's teaching them that they can't escape the food with their problem behavior. But what we often see in those struggles is something that goes so far beyond just this operant interaction that we're talking about. It is our relationship with food is deeply personal and highly reflexive. Kids sometimes gag, vomit. They have the whole gamut of internal reflexive experiences, yet we're simply trying to override that with our operant contingencies sometimes. And I think that could be considered inappropriate.
I'm
I
happy
don't
to-
remember if I answered your question.
No, you did. I mean, look, I just like to kind of wind you up and then let you go. That's the best way to do this. But I am having a little bit of a traumatic recollection of last time we did this, that I took up the whole time asking you questions and didn't let you get to the content that you had. So I want to make sure you have the opportunity to do that. So if you want to pull your PowerPoint up, if there are any points from there that you want to make at this juncture, I'll just try to interrupt as little as I have to try to inform myself. But
You please feel free to interrupt whenever you see fit, because I want to make sure that what we're talking about is useful to the folks that are here.
And I want to remind our audience to either put their questions in chat or just come off of mute and ask their questions themselves if they'd like to.
Please. Can y'all see just the slide, or do you see my presenter view?
I see your slide. I think it's in the right view for us.
Fantastic. Well, so I'll just admit before I get started that last time I came here prepared with about 70 slides of content, and we got through about 18 of them. So there are 52 slides left, but I don't anticipate that we'll get up.
We talked the whole time and never got into the slides. So I'm
Yeah.
very proud of myself that I let you get through 18.
That's right. So we'll see if we can get through 18 more. But so my apologies if I kind of skim over some of the content that I'm talking about. But do please let me make sure I kind of have the chat.
I've got to make sure you get through some of this, because our audience will be upset with me if I don't let you do that. I'll get all kinds of hate mail from that. They'll say, "Oh, you didn't let him talk enough."
Well, broadly speaking, the last time we were together, I kind of tried to provide a behavioral conceptualization of trauma by talking about the fact that we have these experiences at point one, and that whatever the stimuli are in our environment at that point may come to exert sort of this control over our behavior, such that at a later date, when we are faced with that food that made us throw up, when we are faced with the dog that bit us in the past, or when we are faced with just an aversive situation with our care providers as recipients of behavioral services, that we may have reactions to those that are disproportionate to the circumstances, that are, as Bruce and I have been talking about, that go beyond sort of just simple operant ABC contingencies, and that might speak to something a little bit more traumatizing. Another thing that I kind of tried to talk about was the notion that our modern scales for assessing PTSD, post-traumatic stress disorder, all require that the person has language skills, that they can report, that they can kind of think abstract about their experiences and write it on a survey. There's not a great technology out there for nonverbal individuals or individuals with weaker language repertoires to express that they have experienced some kind of trauma in the past. All of that was to make a case that we should perhaps consider a more trauma assumed, or maybe a better way of saying is a more compassionate approach to how we assess and treat dangerous behavior. Because dangerous behavior is still really a problem that these individuals with intellectual developmental disabilities, they should be free of that in their lifestyle. They deserve a better life than one that's replete with dangerous behavior. What I hope to share today, and please do stop me at any point if there are any questions, is simply one such model for assessing and treating dangerous behavior. And I want to be clear that what I'm talking about is not necessarily like a tier 1 intervention, or even tier 2. If you understand that language, it's tier 3. It's the kids that are the most resistant to kind of the mainstream classroom programs, or the ones that require really individualized help, that need kind of a functional assessment and an individualized treatment program. The methods that I've been trained to use are loosely called the practical functional assessment and skill-based treatment process. You can see that there's 2 big brackets there. The first bracket describes the process by which we try to understand the environmental factors that are contributing to behavior, the kind of triggering events or establishing operations, as we might say, as well as the reinforcers, the things that the behavior is producing in the environment that might be the reason that the behavior is occurring at greater frequency in the future. I'll kind of break down what that process looks like, but here's the overview. When we functionally assess problem behavior, I always start by interviewing people that have seen it a lot. I have done years of training in behavior analysis that's given me a certain vocabulary, but that does not in any way, shape, or form make me an expert in your child or your client and their experiences. So I never try to come in and say, I know what's going on. I just always start by asking folks. And I don't need them to speak my language. I like to talk to them in their language. So we keep an open-ended interview to ask questions like, what are the situations in which these behaviors are most dangerous? What do you think the behavior is trying to communicate, if it's trying to communicate anything? And specifically, some of the big questions that I ask are, what are those triggering episodes? What are maybe those reinforcers? But also, what does the entire behavioral episode look like? There are some kids who go 0 to 60 and they're just sitting there and you're not really sure why, but all of a sudden they're biting or they're hurting themselves or hurting other people. But more often than not, there's a little sign, a precursor, a little sign of distress that makes parents, teachers nervous that, oh boy, this meltdown or this bigger episode is about to come. And that information in the assessment process is particularly important. I hope I make a case as to why in a minute, but I never leave my interview without knowing that information. I take this information, and before we move on to a treatment, um, broadly speaking, what we're trying to do is we're trying to get the information that represents when these behaviors are typically occurring. And we're trying to recreate those contexts so that we can teach children skills that they can use in lieu of problem behavior. We're completely assuming that that dangerous behavior is kind of communicating something. It may be communicating multiple things, but there's just this foundational assumption that it's communicative in nature. So we like to teach kids skills like how to communicate for what they need, how to tolerate when they can't get what they need, and how to cooperate during periods where they don't have what they need or what they want. All of that starts with asking these questions on the front end, asking about what are the triggers, what are the problem behaviors, what are the reinforcers.
Curious, Dithu, about when you're going through this process, and one of the things I got trained on, not through my behavior analysis experience, but through some other training experiences that I had, was the importance of establishing rapport with your client, the importance of really honoring the experience that the people before you have had in working with this situation. Because if you step right in and start trying to instruct right off the get-go, first of all, you're likely to be wrong about what you're saying, but also you're going to be invalidating the experience of everybody else involved.
100%. That's, I think, why we start with, please, you tell us. I think that some of the senior folks in my field of behavior analysis who I've been reading for my whole time I've been in this career will readily admit that when we understood the power of consequences in behavior, that it gave us a little bit of a cockiness that we are the ones who know. As I understand it, behavior analysts are not always the favorite person on the interdisciplinary team in schools, sometimes because they come in puffing their chest out being like, I understand behavior, you don't, show me the data. And so I think that starting your process with that level of professional humility is a really important first step. So I appreciate you bringing that up.
Yeah, my grandson does this. He says, you're not on my level. I'm afraid that a lot of behavior analysts do that from time to time.
Yes, you're probably right. Get on my level or get out. But and that's again, I if I'm rushing through things, please stop me. But I don't want to use the language of tell me what the establishing operations are for your child's behavior. I would rather ask, what are the situations where if you were to pull out a jacket, what's the thing that if you were to pull out this homework or this thing that they're really going to have a tough time? And in doing so, Bruce, I think that we do build a great deal of rapport because we are putting the caregivers, the teachers on that pedestal. You're the expert on your child's behavior, not me. My expertise is right here on the bottom of the slide. Like, I know how to take the story that you're giving me and try to sort it into these bins of these are the initial antecedent events, the establishing operations. These are the behaviors you're describing, and these are what I suspect are their reinforcers. And I say suspect because I'm not sure yet. I trust parents, but I want to get some level of verification. And so I do something called a functional analysis or interview-informed synthesized contingency analysis. This is from that advisor of mine, Dr. Greg Hanley. He kind of came up with the term for this, and he developed this modified version of functional analysis. Is it safe to assume that folks here are familiar with functional analysis?
I think they're probably largely familiar, but one of the things I was going to go back to, because you mentioned tier 1, tier 2, and tier 3, which I think if and I may be in the wrong paradigm too, Dithu, correct me if I'm wrong, but you're talking about that's like in a school setting. If we went back to positive behavior supports through the school setting, you have tier 1, which is more or less people just generally like any student that you're working with that needs some sort of support. And then you've got tier 2 where people might need a little step up from that. And then tier 3 are the ones where you've got to really dig in and do a complete workup and functional analysis.
That's exactly right. Tier 1 is school-wide. These are just some healthy contingencies. When all kids submit their homework on time, they all get extra recess. When all kids clean up after themselves, they get, extra recess. Recess seems like a pretty powerful reinforcer in the school context. Tier 2 is kind of, let's go into a small group, maybe not the whole class, just so we can kind of work on maybe some of these social skills or some of these problem behaviors. And then tier 3 is, yes, those kids that are at risk of being kicked out of the school, at risk of being sent to a more restrictive placement. That's what I mean when I refer to tier 3. And I just say that because I know that I'm speaking to a heterogeneous audience here. So if I'm describing something, you're like, well, we would never have the resources for for that. Please drop a line in the chat, because I think that there might be ways that we can talk about how we've adapted this stuff in under-resourced settings. Nevertheless, functional analysis is a tool that behavior analysts have used for a long time, and historically we've used it to try to find the one reinforcer that's driving the bus for any type of challenging behavior, whether it's self-injury, aggression, flipping tables, running away from school. This more contemporary approach, we call it an interview-informed synthesized contingency analysis, because rather than assuming that there's only one reinforcer, we listen to parents, and when parents tell us stories, they tell us very, very layered, nuanced, qualitatively rich details about the situations that evoke problem behavior. You may see right here on the bottom right that for this 4-year-old kiddo, Brandon, who I did this process with, his behavior was determined to be reinforced by escape from any kind of adult-directed activity, from chores, from cleaning up, from getting ready, washed up for dinner. And he would engage in behavior sometime when those events were presented, and it would often result in escape from those events, as well as undivided attention from mom, immediate access to all of his favorite toys and mom's iPhone, and something called man compliance, which basically means that adults in his life would immediately acquiesce to any of his requests.
That sounds like my granddaughter, right
there. You go. Thank you for saying that. I was gonna say, this is something that might seem idiosyncratic, but it's really not. It's young kids. Yeah. When kids don't want to do something, they often engage in bad behavior, what we call bad behavior, and oftentimes it results in them getting to do things that they want. I've seen this with my mother and her grandson, my nephew, more times than I can count. But the thing is that Brandon's behavior was getting really serious. Even as a 4-year-old, he was beating up his siblings. He was hitting his head, and he was having these meltdowns that were keeping his whole family up all night. And to the point where when Brandon's mom came into our clinic, she was convinced that he was possessed. She was convinced that he must be possessed by some devil. And she was she was contemplating seeking some type of religious counsel, because she just thought no normal child, her words, would ever keep their parents up all night with this kind of behavior. And if you just look at the graph, I don't point to data to be like, I'm a behavior analyst, look at my data, kind of like the people I was just making fun of a few minutes ago. But I pointed out to say that when we took the information that mom gave us, that these are the situations where problem behavior is likely to occur, these are the things that I have to do in order to make problem behavior go away. If I were on an airplane, I didn't want Brandon to act out, I would give him my phone, I would let him sit on my lap, I'd do anything he wants, I'd make the funny voices. We took that information and we designed a little experiment. We designed an experiment where in the white circles, what we call our control session, Brandon had free access to those items, free access to whatever toys he wanted. We would do whatever he wanted us to do, and we didn't present any demands or expectations. And when we did that, you'll notice that Brandon engaged in zero problem behavior. Perhaps unsurprisingly, he had all the things he wanted. There were no expectations, no problem behavior. Then when we did our test condition, we just periodically interrupted his way of doing things. And we said, sorry, bud, I need those toys and I need you to go play by yourself, or I need you to go clean up. I'm going to go chat with mom, or I'm going to go do something different. We saw that when that occurred, that Brandon immediately had some challenging behavior. We then went back to a condition where Brandon had all of his stuff for free. And by the way, these sessions are 5 minutes long. So we
Okay.
completed this whole analysis in 25 minutes. It was one single 1 hour visit to a clinic. He came in and we were able to basically, let me say it in simpler terms. We were able to turn Brandon's behavior on, and we were able to turn that problem behavior off, and we were able to turn that behavior on again by simply manipulating things in the environment that mom had reported were part of his were related to his bad behavior. So I want you to think about how powerful that demonstration could be to a parent who has said, I've been staying up all night. She says, no, please don't take that phone away right now. If you do that, we're going to be here for 2 hours and he's not going to leave. And I said, well, could you just let me try it? And we found that as soon as we would take those things away from Brandon, we say, go over there, clean up. And as soon as he had even the slightest whimper, I told you, we look for those early signs. As soon as he said, I don't know, we would say, never mind here. Why don't you take the phone? Why don't you come sit on my lap and we'll clean up. We don't have to clean up at all. And we saw that Brandon's problem behavior immediately turned off in those moments. So after we did that several times, go ahead, Bruce.
No. Please finish.
After we did that a few times, turning it off and on and off and on, we felt like we had enough information to move on to a treatment that I'll describe in just a minute. But I can't state enough how important that demonstration was for mom to see that your child is not possessed, that they are indeed behaving with respect to effective ways to get things in their environment.
And really, when you apply that to almost any referral that you get, any problem that's referred to you, you find it's really not as strange as you think it is. It seems odd, it seems out of the ordinary, but it's really not when you think about all the factors that go into the response the person is having. So,
You're exactly right. So this is what we call our functional assessment process. It's our way of scientifically kind of confirming in a scientific sense, right? Because we manipulated an independent variable and we showed some control over that behavior. It confirms the hypothesis that mom gave us. But more importantly, it teaches us kind of what the establishing operations are. What are those triggering events, and how do we turn the behavior on quickly? And that's important because that lets us know that we have a really nice motivating set of conditions. If this child is motivated enough to go, as soon as I so much as reach for his iPad, then I know that he's motivated enough to learn a new skill, to learn to say, can I have more time, please? And that's incredibly important. And perhaps even more importantly, if we know that when we back off and we give all those toys back and we bring Brandon on our lap, that teaches us that we could turn the problem behavior off immediately. And this is an essential component to trauma-informed behavior analysis. You need to have a kill switch. You need to know that if you're going to go do any kind of intervention with a child, that you have a way to shut the situation down when it gets a little too dangerous. When it gets to that point, like Bruce was alluding to earlier, where we're kind of in this mix between operant and respondent will. And believe you me, Brandon did have the capacity to get into those moments where he's not even in control anymore and it's just meltdown for hours on end. But we kind of had enough information about what are those events that'll shut that behavior off in the moment to move on to try to teach some of those skills in those authentic contexts. So when we move on to skill-based treatment, we take that exact same situation, the situation where he's playing with all his favorite stuff. We go in and we say, you know what, that's all done. I need you to clean up and get ready for dinner. He engages in some type of behavior. In the analysis, it was problem behavior. It was whining, it was stomping, it was pouting. And then as soon as he does that, we then give him all of the reinforcers that he likes, that he values, that he wants in that moment. That's what we do in the analysis. When we move on to treatment, we do the same thing, except rather than reward or reinforce the problem behavior, we teach a replacement skill. In this case, the first skill we teach is the skill of communication. Functional communication training is simply understanding what the reinforcers are and then teaching a functional communicative response, a way to get those things by using your words or by handing over a card or by doing some sort of manual sign or gesture. And that's kind of step one of our treatment process. And what it does, I'll show you kind of data in a second. It has the powerful effect of rendering problem behavior unnecessary almost immediately, because you're teaching the child that they can trust you, that if they just say more time, that you're not going to trick them, you're not going to then make them go do the work. You're just immediately saying, you know what? Yeah, you're right. More time. You can hang out a little bit. In fact, I'll hang out with you. And that's important. And once we see that the child does that, we move on to what's called tolerance response training. Kids can't always have what they want. Kids can, we can't always get the things that we want in the moments that we want them, but sometimes children and adolescents and adults and myself have a hard time hearing the word no. And so, so parents often get into a habit where they just avoid the word no. They'll tell, I've been like a behavior technician, gone into a home that said, we don't say no in this house. I'm like, oh gosh, I'm like, where is the snake that's about to bite me? But
That's
we need
weird. Now that's weird though. If you never use the word no, that's kind of a weird situation. But I mean, I understand why people find themselves in that situation, but the goal ultimately is to have people be able to be in more and more typical types of environments without having to have a meltdown.
Yes, you're totally right. I'm seeing something in the chat. I'm realizing that I missed a few things, but
Yeah, let's skip. Let's look at some of the chat information.
sure.
Babs, you want to process some of that?
Yeah, we had one at the beginning from Janet Schaus that says, how do you treat trauma or PTSD with an individual who's basically nonverbal?
Ooh, yeah, that's a phenomenal question. That's a bit above my pay grade, so I'm out. I'm gonna. No, I'm kidding. It's a very nuanced and layered question that I don't think that we have an excellent answer to. However, I do think that one of the approaches that we found to be successful with children who are basically nonverbal is to empower them with some form of communication, whether it's speech or whether it's kind of AAC, whether it's manual signs. It's so incredibly important that we first kind of do this, the front work that I just described, of understanding what are these contexts where these kind of traumatic episodes seem to be most likely, and when do they flare up, and then empowering children with the capacity to communicate in one way or another, to either say, hey, I just want to get out of this room, I don't want to go swimming today, I don't want to get in the van today. We have a lot of science. We have a whole field of speech and language pathology that's very, very capable of doing that. So that's kind of step number one. And then I guess now that I think about it, I'm kind of going to describe how I would approach these situations for children who are nonverbal. Step number two is teaching them to tolerate when they can't have their way. And I'm it's a little bit more rudimentary than what I'm even saying that it is. But step number three is teaching them what to do in those moments where they can't have the things that they want. And another way of saying that with children who are traumatized, step number three, the contextually appropriate behavior training, is teaching them to systematically approach the things that they fear, to approach the things that are really, really causing them stress and distress in their life, but doing so in a careful, safe, and trusting environment. This is
Just
from
a
so
quick
long ago.
question on this. Ditha, do you ever find yourself in a situation where you have, you've sort of gone through this process and you found that there are things that you pretty much just have to design the environment around this person? And so maybe does this ever become a process of discovery where you say, okay, well, this thing that we need to have in place is a non-negotiable for this person?
I certainly think so. And within this process that I'm describing, specifically the three things that are highlighted right now, we curate a world where we have a lot of control to make sure that there aren't any unexpected things that happen. And we do that so that we can teach reliable contingencies. We could say, when you use your words, this is the outcome. When I deny you and I say, no, you cannot have what you want, this is the outcome. If you say, I'm cool with that, or if you say, okay. But the ultimate goal of what we're trying to achieve here is that I'm not going to get to it. It's kind of
I'm sorry.
it's all good. It's darkened on the bottom, but you might be able to see it. It says treatment extension.
Yeah.
The ultimate goal of what we're trying to accomplish is that the children who have really tough times in certain situations, that they learn to overcome those situations, and that we prepare them and empower them with skills to navigate a very unpredictable social world. Because I mean, yes, there are some things that we can do as a society to better accommodate individuals with disabilities and with trauma. But I don't know that we're there yet. And I think that while we're working on those things, we better also empower children with skills so that they can face their own challenges, so that they can overcome their own challenges.
Yeah, the
That,
problem with the accommodations is they fail at some point. It's not enough. It was not properly carried out when you try to accommodate the environment to somebody. It's sort of like walking on eggshells, and then eventually it breaks through. The more flexible you can help the person become, the better.
I totally agree, and that's going to be a risk benefit analysis that continues to change over time. I'll give you I'll give you a great example. I used to think when I was working with young kids, if they were autistic kids and they didn't like tags on the back of their shirts, I ran into several of those kids. They don't like tags on the shirts, that they wouldn't wear the shirt. And I used to be of the mindset that no, we need to prepare them for a world where there's, they need to learn to tolerate tags. But it's 2022, and there's literal brands that are killing it out there that have made their brand on selling clothing without tags. And so I don't necessarily know that I need to spend their therapeutic time working on this skill.
There you go. Yeah.
If their family, their parents have no issue buying clothing without the tags.
Absolutely right.
You know what I'm saying? I still think that we do run the risk that if they fall into a pool one day and they have to wear their cousin's clothing, that might be a problem. But it's not
sure.
It's not this boogeyman as much as it might have been before, where it's like, oh no, they're not going to be able to be in school unless they can tolerate these tags, kind of thing.
That's great.
Sarah said, so PM, I think that the coat thing, I might have just missed it, but I really loved the point that you made about the interview. It's flexibility in responding to answers. I think that is another way to develop rapport, is not just being like, I'm here because I need answers to 3 questions, then I'm out, but taking the time to say, to empathize with the situations that teachers, parents, paraprofessionals that they're experiencing, behavior technicians as well. And those are kind of the soft skills that I didn't receive in my training, and I'm not sure that I'm very good at it now. But that's those are like lifelong skills that I think we all need to commit to and work on. But Sarah also had this point about when I was probably talking about Brandon's mom saying she felt like her child was possessed. Many parents may not think this is a literal demon, but they still demonize the behavior as manipulation instead of seeing it as cause effect. Could not agree with you more. Yeah, I didn't mean to be provocative when I was talking about this appeal to a demon. So I apologize if I was, but you're hitting the nail on the head. It's just looking at this child as being bad in the moment, being manipulative, and really viewing this as a combative rather than cooperative relationship. And that stuff is equally unfortunate to me when we're trying to really understand how can we best serve this child and improve their life.
Dithu, one of the things I think people think a lot of times, that if you're critical of the use of the word manipulation, which I am quite frequently critical of the use of that word, although I am very tempted to use it on many occasions. So it's not as if it's a holier than thou thing. It's more along the lines of, that's not really helping me very much. And it's not helping the person I'm working with very much to utilize that term to describe things, because it really kind of just sets you up for a negative interaction that's going to perpetuate the problems you're facing.
I think you're right. We could go down this rabbit hole of language that is tough to navigate in these conversations, but I agree with you. Some language, different people come to us with different belief systems about why kids behave the way they do, and we need to take them where they are at. Whether it's I worked in the UAE for a year in Abu Dhabi, and it was pretty normalized that they assumed that children who had autism were kind of possessed by an evil spirit, because that that worldview was so pervasive over there. And again, I came in at a younger age and thought that it was my job to write that, but that's not it. My job is to try to work within your belief system while still being effective and still trying to help this kid learn some skills.
Right. That's great stuff.
Okay, what's the time check? Just want to make sure that I'm.
Well, we're at it. So we might have
Close
to
enough.
have you back for a part 3, Dithu. You're so engaging. It's hard for me to hold back on asking more questions or trying to interact with you because you're so good.
Appreciate that. It would be my pleasure to come back. And for those of you that are scratching your chin going, I thought we were going to talk about trauma-informed care. I'm going to get there one of these meetings.
Babs, we'll get you scheduled again. And maybe by the time we get through this, you'll be part of our 5 Timers Club.
Hey, that could be fun.
Yeah, we've got a 5 Timers Club, and there's nothing that goes with it, but it's just a nice little title to be able to have. Go around and say I'm the 5 Timers Club for CCN. So we'd love to have you in that club. We will get you scheduled again. I mean, this has been fascinating, and I hope we've been able to kind of get through enough of it that people are starting to get the picture of what you're talking about. But we do still need to get to trauma.
We do.
So,
we totally do. I want to make all this make sense. And Babs, I hope I should probably come back sooner next time so that I remember that I'm on slide 24 of 71.
Write that down, Babs. Write it down. And
I got it. I'll write it down. It's all good.
I'll try to dial it back a little bit next time that we meet. And that's going to be hard to do. Maybe we need some other forum where we can talk about other things before we do that to minimize the other banter. But I sure appreciate you coming on and doing this with us today.
It's absolutely my pleasure. I was going to say, I think you and I just need to go to Santa's and just hash this stuff out.
I think if we did that, we could probably get it all out of our system, and then we'd probably be able to do. I'd be able to do a much better interview. But in any case, I appreciate you so much. I'm so glad to have you in Nashville.
Yeah, thank you so much. Thank you all so much for coming. Janet, I do expect a green jacket after three more. So thank you for making me aware that that's the contingency, and I hope to meet it. And yes, I'll be back shortly. I'd be happy to.
Okay, wonderful. Well, appreciate everybody for being here today. We do this every Tuesday at 12:30. So join us again next week for the Clinical Consultation Network. See you, everybody.
Take care, everyone. Thank you so much.